Okay, perfect. So if we kick off, thanks everyone for joining. I'm going to be presenting cardiovascular and kidney outcomes in people with type 2 diabetes and chronic kidney disease with Finerenone. So chronic kidney disease and diabetes. So as we know, chronic kidney disease is one of the most common diseases worldwide. There are approximately 60 million individuals worldwide aged between 20 and 79 years of age with CKD. And diabetes is actually one of those leading causes, with approximately 50% of chronic kidney disease cases associated with diabetes. And that in turn comes with increased kidney and cardiovascular mortality. So currently, as we all know, the clinical guidance recommends optimization of blood pressure and hyperglycemia. In addition to that, we recommend a renin-angiotensin system blocker, so either an ACE inhibitor or an ARB. And more recently as well, the use of SGLT2 inhibitors has been helped to show improvement in microvascular outcomes. So if we can go to the next slide, please. So here we're seeing the effects of mineralocorticoid receptor activity on chronic kidney disease. So what effects does that have on the kidney? And essentially, when aldosterone activates the mineralocorticoid receptor, there's an increase in pro-inflammatory cytokines and pro-fibrotic proteins, which leads to renal inflammatory and fibrosis within the kidneys itself. And that in turn drives the chronic kidney disease with the glomerular hypertrophy, as well as the glomerular sclerosis that is commonly seen on biopsy within people with CKD. So Finerenone. So this is a new novel agent. It's a non-steroidal mineralocorticoid receptor antagonist. And this is different in terms of the pharmacokinetics as well as the clinical effects to standard steroidal MRAs that we use, which are spironolactone and eplerenone. And in animal models itself, it's been shown to reduce inflammation as well as fibrosis. Finerenone does not significantly reduce blood pressure, so we don't see any antihypertensive effects with that. But certainly there are reduced steroid-induced side effects, so that the typical gynecomastia and the low libido that we typically see with spironolactone and eplerenone are reduced.
Next. I'm surprised that it doesn't drop blood pressure if it is a non-steroidal antagonist, isn't it?
Yeah. I thought so too, but in all the studies, it doesn't have a significant blood pressure lowering effect. Okay. So recently in the literature, there have been a couple of really big studies that have been done looking at Finerenone. And essentially the paper that I'm going to talk about is looking at the pooled efficacy and safety analysis on the safety and efficacy of Finerenone compared to placebo in people with CKD and type 2 diabetes. So in this, sorry, was there a question?
No, it's just a bit of a noise. Carry on.
So there are two large multi-centered clinical trials that are included in this pooled analysis. Firstly was the Fidelio DKD, and that was with approximately 3,000 patients published in New England Journal of Medicine in 2020. And that was then followed by Figaro DKD, which was published in 2021, also in New England Journal of Medicine. And both the studies are very similar, and I'll talk about them and the trial study design. But the only difference between these two studies was that in the first study, the composite outcome or the primary outcome was a measure of kidney failure, as in the name itself. Fidelio was standing for Finerenone in reducing kidney failure and disease progression, versus the second one, which was Figaro DKD, which was reducing cardiovascular mortality and morbidity. So both these studies were randomized 1-to-1 Finerenone to placebo, double-blinded, placebo-controlled, conducted across 48 countries and looked at a total of 13,000 individuals in the pooled analysis between those two clinical trials. Next slide, please. And this is a summary slide sort of showing the differences between Fidelio DKD and Figaro DKD. And really, what I just wanted to highlight was in terms of, and I do apologize, the slide is slightly out of place, so I don't know if you can see very clearly, but essentially for Fidelio DKD, I was highlighting that the primary outcome was chronic kidney disease, as mentioned before, and the composite outcome was time to kidney failure, versus Figaro DKD, which was cardiovascular disease, time to cardiovascular death was their primary outcome. The inclusion criteria for both studies were type 2 diabetes with CKD, but there were some very subtle differences in their levels of hyperalbuminuria and eGFR. But when pooled together, actually there's a wide cohort of individuals, which we'll go on to on the next slide. So I've kind of gone back to look at the inclusion criteria just because it's, I think, a bit easier to see rather than in that really busy table. So adults greater than 18 years of age were included. Individuals who had type 2 diabetes and chronic kidney disease were included for both studies. And like I mentioned earlier, there were just some very subtle differences between the two studies that were done there in terms of the level of chronic kidney disease that they had. All individuals had to have had prior treatment with either an ACE inhibitor or an ARB, and they had to be at the maximum tolerated dose. And individuals had to, at point of screening, had to have a potassium less than 4.8. Next slide. Thank you. And so for the exclusion criteria, individuals who did not have diabetic kidney disease, so non-diabetic kidney disease, were excluded, or if they had a HbA1c of greater than 12%, uncontrolled hypertension, symptomatic heart failure, recent cerebrovascular accident, or if they were on dialysis or had a kidney transplant, were the main exclusion criteria. Next slide, please. And then just a little point about the medications as well. If anyone was on eplerenone, spironolactone, or any renin inhibitor and couldn't be discontinued for more than 4 weeks prior to screening, then they were excluded as well. Concomitant, so dual use of an ACE inhibitor combined with an ARB, was also excluded in the study. And they did accept people onto the study if they were able to drop one of those medications 4 to 6 weeks prior to their screening appointments.
But they're worried about high potassium, aren't they? I wonder, like 4.8, does that cause Finerenone makes it go up?
Yes, so we know with spironolactone as well as eplerenone that people can get hyperkalemia. So that was one of the things that they looked at. And I'll come on to that because they have given the incidence rates of hyperkalemia in the study. So I think they were quite concerned about it even from the start when they were designing the study itself. So this is the study design, and individuals went through a run-in period of 4 to 16 weeks. And then, Prof, if you can just go to the next slide. So during this time, they maximize the dose of either the ACE inhibitor or the ARB during the screening, during the run-in period itself. Then at screening, they will reassess the eligibility. And then after that, they get randomized to either Finerenone or placebo. And individuals were, in terms of the dosing of Finerenone, so they received 10 milligrams once daily if their eGFR was between 25 to 60 milligrams a minute, and then 20 milligrams once daily if their eGFR was greater than 60. And the dose could be titrated up and down depending on either their potassium values or their eGFR. And then if we can go to the...
Yeah, that dose titration in the placebo group as well, so they don't know what they're on.
So the endpoints that we looked at, that were looked at in this pooled analysis, was looking at both a composite cardiovascular outcome, and that comprised of time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And then it separately also looked at a composite kidney outcome, which was time to first onset of kidney failure, a sustained greater than 57% reduction in eGFR from baseline over 4 weeks, or renal death. And the 50% is used because apparently that's the cutoff thresholds that they used in most of the renal papers. And then in terms of the secondary endpoints, they looked at a second composite kidney outcome, which was looking at the time of first occurrence of kidney failure, and then a sustained greater than 40% reduction in eGFR. So that's different to the 57% that we see in the main primary outcome. And then they looked at all-cause mortality and hospitalization and the safety analysis, which we'll talk through. So here, this is looking at the range of the demographics for individuals that were randomized to either placebo or finerenone. And in both groups, individuals had, there were more than 6,500 individuals randomized to each of these arms. The mean age was 65 years, and more than 2/3 of individuals were male, with about 1/3 being female. And in terms of the ethnic backgrounds, there was quite a mix. So about 1/4 of individuals were of Asian origin. However, Black and Afro-Caribbean ethnicities only made up 4%, so a bit low in that cohort. And the duration of diabetes was about 15 years as the mean. There were no significant differences between the two cohorts. And so this is looking at the primary outcomes. And Prof, I think there's one more slide before this. Yeah.
So this is the last one. Yeah.
Yep.
This one you want.
Yep. And then the next one. Sorry, because I think it had gone two images before, 2 slides. I think there should be one before this.
No, this is only. Shall I go for another one?
This one.
Okay.
Yeah, thank you. So this is looking at the composite cardiovascular outcome. So the red line is placebo and the blue line is finerenone. So firstly, for the image on the left-hand side, we can see that the cumulative incidence for finerenone was significantly lower than that for the placebo cohort. And then when we look at the image on the right, which is looking at an eGFR of greater than 57% reduction, again, we can see that finerenone had a significantly reduced incidence compared to placebo.
Go back to the other slide then.
Yes, please.
I'll go, hang on.
Sorry.
That's C and D.
Thank you. And then they also looked at the composite outcome for those which had an eGFR of greater than 40% reduction from baseline. And again, significant differences between finerenone and placebo. And finally, death from any cause did not quite reach statistical significance, although there appeared to be some benefit with the finerenone, but the 95% confidence interval reaches 1.
Okay.
And then the following slide. Sorry, this is not come out very clearly, and unfortunately on the shared view. But essentially, this is looking at a forest plot which compares finerenone and placebo. And we've seen all the data already on the slides before, but the one bit that I was going to point out was also looking at hospitalization for heart failure. And actually, there's a significant benefit with finerenone versus placebo. And I think that will be a really interesting area to look at in terms of prognostic benefit for people on with heart failure as well in the future. And sorry, that's not come out clearly there. So this is looking at the adverse event profile between Finerenone and placebo. And the main thing to look at here was, I think, the hyperkalemia incidence. And I've highlighted that on the next slide, Prof, please.
Yes, I'll just point out, it says fatal hyperkalemia, 0.
Correct. So when we look at investigator-reported hyperkalemia, there does look like there's a significant increase in the incidence, as with those which have had serious hyperkalemia. So the numbers are still small. They're still making up only 1% of a cohort of 6,500 people. But there are noticeably a few more than the placebo cohort. But in terms of the fatal hyperkalemia, actually there's 0 in the Finerenone group.
But also there's more hyperkalemia. Have I got this right? Or no, what's this 149? Infected hypokalemia, I see.
Yeah, they've talked about hypokalemia as well. Slightly less. I didn't make too much of the hypokalemia incidences that they noted.
Yeah.
So really, just to summarize here, so Finerenone reduces the risk of clinically important cardiovascular and kidney outcomes compared to placebo. And essentially, we've seen a 14% relative risk reduction for the composite cardiovascular outcomes and a 23% relative risk reduction for the composite kidney outcomes. And in terms of, next slide, please, in terms of some of the things that I thought were sort of quite key really to point out here, because I think that this is a really important pooled analysis that they've done. One thing that struck me is that it is really important to get all these individuals onto the maximum dose of an ACE inhibitor or an ARB. I think what will be quite interesting, which I'm sure that the sub-analysis of these studies will sort of go into, is whether there might be any additive effect of a combination of Finerenone on top of an SGLT2 inhibitor or a GLP-1 receptor agonist. I think that Finerenone is going to have certainly a big role to play in clinical practice, because certainly we also know that not all individuals are able to tolerate or have an SGLT2 inhibitor or a GLP-1 receptor agonist. So I think having another third agent which has got proven benefits in terms of kidney outcomes is really important. There is that risk of hyperkalemia that we talked about, but as Prof, you also pointed out that there's no, there were no incidences in a cohort of 6,500 people of fatal hyperkalemia. And finally, I personally thought this was really interesting, and I've sort of just talked a little bit, I thought I'd talk a little bit about it, but both these studies, Fidelio DKD and Figaro DKD, are studies that have been funded by Bayer, and all their analysis and everything has been done by them as well. And normally, whenever anyone sort of funds a large pharmaceutical company, I always sort of, think twice about these things. But what really struck me is, given that the way they design these studies, actually we've been able to do such important individual patient level analysis and a comparison across studies. Whereas I think that, sometimes when I look at all the SGLT2 papers that we see with, their outcomes in terms of chronic kidney disease, actually it's so much more difficult to do a pooled analysis, because they all have slightly different study designs and they've included different individuals and things. Whereas I think these studies, being designed by the same funder has really allowed us to do a really huge pooled comparison, which I think has been really helpful. And then if we go on to the next slide, I thought I'd just give you a little bit of update on the market authorizations on this. So FDA approved last year in September. MHRA authorized a few weeks back. And the NICE technology appraisal is expected for publication in August 2022. So this is for people with type 2 diabetes and chronic kidney disease. And I certainly think, as diabetologists and endocrinologists here, this will be an agent that we'll be looking to probably use in the future. Thank you.
Yeah, I'm sure you're right. I'm sure it'll be expensive though, because we've got to pay for this study now, haven't we? The world.
Sorry?
The world has got to pay for the study now, so it won't be a cheap drug, I don't think. It looks very
No.
good.
That's a good question. I haven't had a chance to look up how much this drug costs. So I think, Mohsin, you asked what is the numbers needed to treat. That is a good question. I can't remember the exact numbers needed to treat from their numbers that they had required to analyze. But in terms of the participants that they recruited, they had 5,000 in the first study, which looked at the chronic kidney outcomes, and they had 7,000 in the second study, which looked at cardiovascular disease as its primary endpoint. And they've also published their protocol and things like that. So they've definitely done their statistical calculations for their numbers needed to treat prior to study recruitment.
I think Mohsin is not asking you about whether the study was valid. I think he's asking you how effective is it? Yeah, if it's a large number to treat, then it'll be expensive. I think that's the bottom line. Because yeah, I mean it's not as good as EMPA, is it? But
yes, but I think that not everyone is going to be able to go on to an SGLT2 inhibitor for various reasons. We see, with urinary tract infections or thrush, and therefore I think that having an additional agent might be quite helpful.
I mean, the numbers here, so that looks, let's say that's what 1% relative risk reduction. Yeah, what do you think, Mohsin? So it's not a huge difference in terms of numbers of people. If you need 100 people, you might get, after 4 years, you might prevent 1 or 2 events. That's what I think. So that's not terrible. That's quite good.
I think in terms of the cost benefit analysis, I think is quite difficult, because if you're preventing even a few individuals to go on to dialysis, the cost of dialysis is going to be significantly high as well. So I think that given what a burden chronic kidney disease is, I think there is going to be a role to play, but I don't know the exact numbers off the top of my head, sorry.
But the problem with trying to do that kind of study is, of course, if someone dies, then it's free. Yeah. So when you have a death analysis, if the finance comes into it, then of course death is a good outcome. So the financial argument, you see what I mean? Because what you say is the minute you save a life, you've got to spend some more money. So it's very difficult to cost these things. They've said it's £30,000 per quality adjusted life year is what the world is willing to pay. Yeah, that's a value judgment. Any other about this? I mean, spironolactone is really cheap, so that's it needs to be better than spironolactone. I think is the next thing. It's interesting. It needs. I think they were hoping it would be like EMPA, a surprisingly fantastic good outcome early on, which hasn't happened. Do you remember in EMPA, the curve at the beginning diverted at 6 months?
Yeah,
that hasn't happened with this drug. So.
Yeah, and EMPA is quite different in its use, isn't it? Because it also reduces hyperglycemia, and we also have a blood pressure lowering effect. So it might be that given the other benefits of EMPA, we're seeing earlier improvements in kidney and cardiovascular outcomes.
Yes, I mean, this study is much like that in terms of longevity, how they designed it. And I wonder if I was the company, Bayer, thinking, I wonder if we do this, because it's like spironolactone. So you would expect a good outcome early on for heart failure, which hasn't really happened for 4 years. You know what I mean? They were looking for the 6-month thing. I know they don't say that, but that's what happened in EMPA. It seemed to reduce heart failure within 6 months.
Yeah, quite quickly.